Morning, everybody. I wanted to start with a thank you to our joint sponsors, DWF and Commercial and Clinical Solutions, this morning for their support for this meeting and for their support for RESEC. I come to you this morning with three hats on. I'm a GP. I work in a practice out in the Fens, just east of Peterborough. I look after a care home where all the residents have dementia, and many of them have behavioural problems. And I've been looking after this population for over 10 years now. So a lot of my practical experience is around those people. And I'm conscious of the way general practice delivers care for people in care homes generally, and in particular really often fails to deliver care. I'm also the RESEC Research Fellow at Green Templeton College in Oxford, and much of my research work, which I'm going to present to you today, has been based around that interface between general practice and the care home sector. And finally, just at this point in time, for 6 months, I've been seconded from my practice to be part of a pilot project in Peterborough, trying to prevent hospital admissions, emergency hospital admissions for frail elderly people, to keep them out in the community and to look after them there. And I'll bring you some early results from the first few weeks of that pilot project. So, a few quotes to begin with about the care home population, which over the last 20 to 30 years, since people moved out of the long stay geriatric wards in the hospitals into the care home sector, has progressively changed as that population has expanded in size, has been living longer. And we know that in our care homes now, at least 2/3 of people will have dementia, even if they don't have a formal diagnosis. And if you look at these quotes from 3 recent publications, you see the words poor quality of care and failure of the NHS to deliver good care to patients who are increasingly complex and needy in terms of their medical problems. And so much of what I've been doing is trying to look at the way primary care interfaces with the care home sector and the way we deliver care. And it's led me to think about a model of best practice, because there is to date no model of best practice. There's no agreed way in which general practice actually delivers care for the patients that it has in the care homes. And so I think, and this is based on my experience on talking to other GPs, on talking to people in the care home sector, that actually what we need to do is to get back to the idea of an individual GP looking after all the residents in a particular care home, taking personal responsibility for those residents and having a continuity in terms of their care. Visiting regularly, developing a proactive approach to their care rather than purely reactive. For many residents in care homes now, they only see a GP if the care home staff decide they've got an acute problem and they need to be seen. They never have an opportunity to see their GP on a more proactive basis. We need to take a holistic approach to their medical care, and these are often people with very complex comorbidities. The quality and outcomes framework in general practice now, the way we're all encouraged to work, is a very task-driven, target-focused approach. Individual diseases are looked at, and looking at the whole person's got lost in the middle of that. I think we've got a great deal we can do, particularly in relation to looking at the medication that we prescribe, and being rigorous in addressing that can make an enormous difference to the people we look after. And we need to have a burdens and benefits approach to assessment of someone who might need hospital admission. Does the benefit of hospital admission for this person really outweigh the burdens of going to hospital? Because we know that for people with dementia, hospital admission leads to poorer outcomes in terms of symptom control, pain relief, palliative care interventions, and mortality. And in our work in the care home, we need to take that symptoms-based approach. Pain control, nutrition, mobility issues, continence, these are all areas where we can have a really major impact and make a change to the medical care we deliver and to the quality of care for those residents. So this has been the focus. This idea of a model of best practice has been the focus of my research. I need to provide some evidence to prove to people that actually maybe this is the way to go. So the first bit of research I've been involved with RESEC was a questionnaire survey. I wanted to find out what was happening on the ground. So, what were GPs doing? What was the experience from the care home side of things in terms of visiting GP practices? I wanted to look and see, were care homes having a single GP practice attached to them, or was there a huge range? And what was happening about GP visiting? Were GPs going regularly, or were they just going on demand? I did this piece of work with the European Care Group, and 47 of their care homes took part in a questionnaire survey. So this was looking at over 1,800 residents who were being cared for by 162 GP practices. And there was actually a range of between 1 and 15 GP practices per care home. So some care homes had got, if you have GP practices with 4 or 5 doctors, then you've got 15 GP practices going into a care home. You can do the maths. There's a huge number of different GPs that could be going in to see a relatively small number of residents. And the continuity of care in terms of the residents, but also for the staff and building important relationships, is likely to be very difficult to achieve. Only 23%, so less than a quarter of GP practices overall, were making a regular visit to a care home. When I looked at the different care home types, 40% of GP practices were visiting their nursing home where they had patients regularly, but in the residential homes that fell to only 7% of GP practices actually making a regular visit. But the other finding that came out of this survey was that actually GPs are significantly more likely to make that regular visit if they have larger numbers of registered patients in the care home. Now that may seem so obvious, it doesn't even need saying, but actually it's a piece of evidence that wasn't out there, that actually if you want to persuade GPs to make a regular visit to a care home, then we need to be aligning GP practices with care homes so that you have a single GP practice for that care home. I looked at the number of doctors in a practice, the number of partners in a practice, whether or not the practice was a training practice, and this didn't seem to have any influence on whether or not a regular visit to the care home was made. Whilst I was doing this work, I was talking to the PCT in Peterborough, where, as is typical of many inner city areas, there are large numbers of care homes with a lot of GP practices with crossing boundaries. And I was able to demonstrate to the GPs in the city that there were GP practices that were visiting 16 different care homes, and that there were care homes with 17 different GP practices going in. And so we developed over a period of a few years a locally enhanced service contract between the GPs in Peterborough City and the PCT to align an individual GP practice with a care home. And with that came the responsibility that the GPs made a regular visit, took a proactive approach to care of their patients in that care home, with a particular emphasis on a holistic approach and end-of-life care. And remember, as I said, many of these residents will have dementia, even if they don't have the formal diagnosis. I looked at the number of emergency hospital admissions from the care homes prior to this alignment and the contract being established. And then after a year for everything to shake down, I looked at emergency admission numbers again. By the end of that time, 12 of the 15 care homes I was studying had an aligned practice, and 70% of their residents were registered with the aligned practices. Now, there were some other initiatives going on over that time, and I can't claim all of the fall in emergency admissions to the alignment, but I'm sure it was very significant. We had 125 fewer emergency admissions in the second year post-alignment. That's a 27.2% reduction. And if you think about an average hospital stay of 15 days, that's potentially more than £1 million. Now, you know, I'm not interested in the money, but there are an awful lot of people that are. And if you can produce the figures, you can persuade people and carry them with your arguments. Having looked at the question of regular visiting by GP practices, I need to demonstrate whether or not there is actually an impact on the quality of care that care home residents receive if GPs go regularly. If I'm going to persuade my GP colleagues that we need to adopt this sort of model, that we need people as GPs to be going in regularly, then I've got to prove to them that there's a benefit to it in terms of patient care. And hard data of quality of care is difficult for this sector of the population. You're not looking at gold standards for ischemic heart disease or gold standards for someone with diabetes, you know, the top level care. You're actually looking at something much more complex for these individual residents. And so emergency hospital admissions remains something that we can look at as a marker of quality of care. And I feel that because I think that if you regularly visit your care home patients as a GP and you take a planned approach to their care, you then can reduce the risk of emergency hospital admission for them. And that reduced risk undoubtedly improves the quality of care that they're receiving, because, as we've said, emergency hospital admission is something that to be avoided, if at all possible, for people with dementia in particular, but for the frail elderly in general. They are not well served by emergency hospital admission unless there are clear benefits from that happening. The work I've been doing on this basis is working with one of the leading UK care home groups, and they have 289 care homes in the country and look after over 17,000 residents. Unlike the national picture, actually this particular care home group have a much heavier weighting of nursing homes to residential homes. I know the national picture is normally the other way about. And as you can see in general, in their group, the residential homes tend to be the smallest, the nursing homes are middle-sized, and they're dual-registered homes, some of which have mixed residents, nursing and residential residents together, some of which have individual units, tend to be the largest. This research is now ongoing, so have completed the first phase, which is to look at the hospital admission rates from all those care homes. And the second phase will then be to look at the numbers of GP practices for each individual care home, the care home GP visiting patterns, and to see whether or not there's a difference between exposure to regular visiting or just reactive visiting on demand in relation to hospital admissions. Now, what I found, really just by asking in the care home that I look after, well, what do you keep on your computer? You know, what data do you put in there? I know all of you have got computers, but what's it for? And I discovered, of course, it's for the finances. And within the financial data, every time one of the residents was admitted to hospital, they were logged in as temporarily discharged from the care home. And then when they came back again, they were readmitted to the care home. And we could take that finance data and use it to identify every hospital admission for all those residents, by care home, by length of stay, by time of year. So an absolute gold mine of information that was hidden in an unexpected place just by asking the question. And I'm enormously indebted to the IT guys in the finance department for extracting vast swathes of data for me. But the staggering thing is that when I was wondering whether would there be enough hospital admissions for me really to look at, would I have a statistically significant number? Over 9,000 hospital admissions in a 12-month period from 17,000 residents. For me, as a GP, that's a huge number of hospital admissions. So I was able to look at the hospital admission rate by care home. And as you can see, overall, there's one hospital admission for every 2 residents over the 12 months. When you break it down into the different care homes, you might expect that the nursing homes with their medically more complex patients would have a higher admission rate than the residential homes. But in fact, the nursing home admission rate was statistically significantly lower than the residential home admission rate. In other words, you've got a much higher chance of being admitted to hospital in a year if you're in a residential home than you are in a nursing home. Now, I have to say, from a GP perspective, if you took me into a dual registered home with nursing and residential patients mixed together in a unit, I could not tell you who was nursing and who was residential, because the complexity and the frailty of the people now in our care homes is such that actually, from a GP point of view, it's very difficult to tell. And I don't fully understand, despite talking to my social care colleagues, how these things are decided either. But it does make me feel that in residential homes where we've no nursing staff, we are clearly failing to provide adequate medical and nursing support to support the care staff and the residents if they've got a higher admission rate than a nursing home has. I looked at the length of stay in hospital, and as you can see, the majority or the highest number of admissions were in the 3 to 7 day range. We know with this data that the really long admissions, the finance data is probably inaccurate on. So up to 14 days, I can say with some accuracy that those are the figures, but not at greater stays than that. But actually, I'm quite interested in those less than 3 day stays, because there's still quite a significant number. And maybe some of these are relatively minor events, where again, better medical and nursing support might have prevented people having to go into hospital. There's no real seasonal variation in these admissions. That's the on your left, the graph on the left, which I think doesn't actually reflect a normal hospital picture in terms of you would expect a seasonal variation, but that actually doesn't seem to be happening. I can't pick out of hours from GP admissions in terms of the 24-hour period, but I can show you that at a weekend, on a Saturday and Sunday, the admission rate was actually slightly lower across all the care home types, and actually Monday's the peak day for hospital admissions. I was interested to know at an individual patient level, what the percentage of what I call the frequent flyers was. In other words, if you were admitted to hospital once in a 12-month period, what was your chance of actually being admitted more than once? In this whole over 9,000 admissions, there was one resident who had 10 admissions in a year. In the nursing homes, about 3/4 of those residents that were admitted only went in once. But actually in the residential homes, that was only 2/3. So 1/3 of residential patients that were admitted went into hospital more than once in the 12-month period. And again, that suggests that if someone's been admitted and returned to the care home, where's the planning? Where's the questioning? Why did this person go in? What could I have done? What was the benefit of that admission, and what could I, as the GP, have done to make a difference to reduce that risk in future? But this is the thing that really interests me. You've got 3 residential homes. They've all got the average number of residents. They've all got residents with similar diagnostic, or they're in the same categories. They're all frail elderly, many with dementia. They're all located in a town. But there's a nearly 6.5-fold difference between Home A and Home C in the admission rates over the course of the year. And I want to know why. What's the difference between those homes? And what I'm hoping to show through the next phase of my research is actually that the GP visiting pattern has at least some impact on that, though there may be many other factors. But that's a very significant difference. And actually, when I looked at nursing homes in the same way, slightly different geographical locations for these 3 nursing homes, but again, otherwise, same size, same frailty of residents, but an 11-fold difference in hospital admission rates over a year. And you have to ask the question, what's going on in Home F? That there are 56 admissions for only 48 residents over the course of a year. My own take on this as a GP is to try to think, how can I protect my patients from hospital admission when I'm not there? We have advanced care plans now, and we talk quite a lot about it, particularly with respect to people with dementia, in terms of trying to capture a patient's wishes, their relatives' wishes, those closest to them, a best interest thoughts on where they would best be cared for, preferred place of care, preferred place of death. And certainly in the care home I look after, we try to record that. We have do not attempt resuscitation orders, but those are specific to a relatively rare event, a cardiopulmonary arrest. And we have nothing in the middle from a medical perspective that says to the staff in the care home, says to the resident, if they're able to comprehend, says to the family, and says to any visiting health professional out of hours, this patient's to stay in the care home. So what I've come up with is something I call the RICH plan, the Remain in the Care Home plan. I use an algorithm that comes from the National Council for Palliative Care, which helps to identify when someone with dementia has reached a palliative care stage of the disease. And having made that assessment, I then undertake to acknowledge that that person needs to stay in the care home and needs to have adequate medical and nursing support for that, but to have their care delivered in that setting where they're known, where the staff know them, where the staff can care for them, rather than being admitted to hospital except in exceptional circumstances when the benefits of that admission clearly outweigh the burdens. So, a hip fracture, yes, somebody would need to go to hospital. But if they had a stroke with advanced dementia, no. Not unless there was something really acute that I felt that where the hospital could make a huge difference. They stay with me in the care home, and we put in the support and we look after them there. And then this is a signed form. It's signed actually by the family to say we've had the discussion, they understand. It's signed by the staff to say they're part of this decision. And then I take the responsibility, just like with the DNAR form. The responsibility for signing is mine, and I my signature at the bottom. So that this is something that I have discussed with people nationally who are involved in looking after the care home population and particularly those with dementia, and has been well received, and we now have that available on a website, and I can give anyone who's interested the address. We have a website attached to my practice website, and this plan is available to download. There's an information leaflet for relatives and carers. There's a protocol for its use, along with a whole raft of other practical tools. Because in the end, it's about practical tools. We're going to say to people, we need to improve care. We need to facilitate that delivery. And I so often have found that the thing I'm missing is the bit of paper, the tool that allows me to do that. So that's what the RICH plan's about. My final hat this morning is to be, as I said, seconded at the moment to a pilot project which is being funded by Peterborough City and what's called the Borderline local commissioning groups, and we're called The Firm. We sort of hoped that Tom Cruise would come rushing through those. We're all 3 lady GPs, and we were optimistic, but it hasn't proved to be the case. So we're a team of 3 experienced local GPs, making up 2 full-time equivalent GPs, a local consultant consultant physician for older people from Peterborough City Hospital, and one of his colleagues backing him up on 1 day a week. So again, we have 1 full-time equivalent consultant with us. So for him, this is a really new experience. He's out in the community visiting people in their own homes, something that he's not really ever done before. We have a community matron who's linked to our intermediate care service from the community services. We have a social worker from adult social care in Peterborough, with a special authority to fast-track things, to make a difference, to get things going. And we have administrative support, project leader and admin staff, because this pilot project is being formally evaluated, and so we can show if there is a cost benefit to it. So the key aim is to improve the quality of care of frail older people during an episode of acute illness, and to reduce their risk of emergency hospital admission. We're also sometimes scooping people out of the emergency department and getting them home if we feel we can meet their needs at home once they've had an assessment. We're trying to reduce pressure on secondary care beds, which at this moment we seem to be in Peterborough City Hospital, along with many others in the country, seems to be in crisis, black alert every day. And of course, trying to reduce private care costs to prove that we are a cost-effective way of working. So it's an interesting experience. I've been back in the casualty department, the emergency department, for the first time in 30 years. And I have to say that I didn't really need convincing that it's not a place for frail elderly people before I went, but I'm absolutely certain now. The sense of fractured care between the first bit and the 4-hour breach, and then a whole new team of different people, medical and nursing, is really distressing and worrying. And in a very few short weeks, I've seen some very good care, but I've seen some examples of care that I was very concerned about indeed. And there is a sense of low morale and impotence that is really worrying. People feeling they just can't make a difference, so they're grinding through. And patients don't get the best out of us if that's the way everybody feels. To date, we have, this was an analysis on the 7th of March, after the first 25 days. We're only working Monday to Friday, 9 to 5, in terms of being actively there and accepting patients, but we have a sort of enhanced handover to the out-of-hours service, and they have access to our records at night for our patients, and we have a doctor who does a shift on Saturday and Sunday specifically to visit our patients. So there is a level of continuity. That number of total referrals so far has gone up to 109 by the end of last week, of which we'd accepted 66 and declined 43, mainly because alternative pathways were more appropriate, but sometimes because of a lack of capacity. We had nowhere to place people safely and look after them. We are looking after most people at home, but we also have some beds on a nurse-led intermediate care unit housed in the same building. We have 4 ring-fence beds there, and we're bringing people in there. I have to say that unfortunately that the one team that really hasn't engaged well with us is the mental health team. They were supposed to be a partner in this. They were supposed to produce a rapid response for us. And they've really said, well, you just have to go with everybody else. And they haven't really engaged, which is disappointing for us. And so we're tending, as we do in general practice, just to do it ourselves and get on with it. But that's where we are at the moment. And it is proving very interesting, quite challenging at times. We're uncovering some extraordinary contracts, some of them about minor things, but things that have been negotiated and accepted and recognised as being not fit for purpose, but nobody feels that they have any ability to challenge or change things. And again, you know, coming from general practice, we are not good at following rules. We don't do what we're supposed to do. And so we're saying, well, hang on a minute, why? And, you know, I think it does ruffle a few feathers, I have to say, but actually they need ruffling badly sometimes. So I wanted just to finish with a story, actually, because I think there's sometimes a sense that, you know, these frail elderly patients, those with dementia, have reached the end of their lives. Yes, we can look after them, we can take care of them, but actually, really, there's very little we can do, isn't there? There's little big difference we can make. This is a lady of 90 with vascular dementia who'd been admitted to hospital after a series of falls, and her husband could no longer look after her. She was, in the end, discharged from hospital to the care home that I look after. And we were told when she came from the hospital, this lady has no potential for rehabilitation. She was needing a hoist for all her transfers and cares. She'd had a speech and language therapy assessment which said she had some swallowing difficulty, so she was on a pureed diet, but normal fluids and supplements were recommended. She only weighed 39.5 kilos. She had a past history of constipation, so as well as lactulose and senna as laxatives, she was having twice weekly enemas. Now, when she came into us, we couldn't really identify a major swallowing difficulty, so we started to gradually introduce a normal diet, which she managed. We tried to mobilise her just to see, and she complained quite consistently of pain in her knees. So I gave her a month's course of a non-steroidal anti-inflammatory, and then converted that to just as required paracetamol. And over the course of that month, she managed to mobilise between 2 people. We stopped needing the hoists, and she was clearly much more comfortable. And she's able, and has been since that time, to walk short distances between 2 people. 12 months later, this lady had a Bartell score of ability to perform activities of daily living of 54 out of 100. It was 8 when she came in. She was eating everything put in front of her with evident enjoyment and weighed 57.5 kilos. She's still walking with the help of two. Her bowels are now open regularly with a change of laxatives, and she doesn't have any more enemas. But I know her as the lady with the bubbly white curls and a wonderful smile, who clearly enjoys her food, who enters into the activities in the home, who knows her family and enjoys their visits. And this is someone I was told had no potential for rehabilitation. So there's a huge amount we can do. And we owe it to this very vulnerable sector of the population who don't have a voice to do it for them. Thank you.